what is it that we expect to see now with the rollout of the vaccines? Then what do you expect to see with the rollout of the next vaccine rounds and how they arrive? And what is the, like CT, you were saying, what kind of awareness creation needs to go out in this? Are we likely to also see some emergence of groups that are going to be opposing the vaccination exercise in Kenya? So, how many doses of vaccines are we expecting in the country next month? 24
24
million.
million.
Okay.
And where are they coming from?
Various sources, according to the CS for Health, right?
And does he mention the sources?
Let me look for that where he's quoted as having said this yesterday. We have both public and private. No, not know that. The government has procured vaccines alongside the Africa CDCs, which is a purchasing platform through the African Union, and the other is private healthcare partners. So the private healthcare partners are doing their thing as they're doing, but the government is basically purchasing these ones for the AstraZeneca vaccine, which is also will be accessed by private partners that would ship it into the country. So we're doing the AstraZeneca one, the first batch, according to what has been quoted here as and attributed to the CS for Health, Senator Mutahi Kagwe. Okay. And then when they arrive, then there's going to be now that whole prioritization of who gets, who doesn't. And then how do you address the fears of the public? Okay, so these vaccines have just arrived, and at the same time, we are seeing them in these private hospitals, and at the same time, we're not hearing who's being vaccinated, and at the same time, we're hearing that doctors have been fired, so they're not getting the vaccine. So, so who's getting the vaccine if not the doctors because they've been fired, or the nurses because they've been? That whole issue will need to be very well managed. And it's a point here that also we need also to understand, so what is this vaccine and what is it all about? And to help us have this conversation this morning is Professor Anzala. Anzala is an expert on matters of virology, right? And he understands these matters very well. He's one of the people who we call the brain trust that has been advising the government on how to handle and manage the spread of COVID-19 in the country. Good morning, Professor.
Morning. How are you guys?
We are very well, thank you. And it's good to hear you this morning. Happy New Year.
Happy New Year. It's a while since we talked. So you are staying safe?
Well, yes.
Right. Yes.
Yes, COVID hasn't gone away, ladies and gentlemen. Stay safe.
We always try to do that, Prof. Now, in fact, before we even talk about now vaccines, let's talk about the COVID. This curve, it goes up, it comes down. So from one moment, we are seeing positivity rate of double digit. Then within a couple of days and weeks, we see it come all the way back down to below 4%. And then we see it shoot up again. What is determining this pattern?
Yeah, you see from the very beginning when COVID started, 2019, and then 2020, we have been trying to understand, and I'm sure you guys recall me talking to you guys about the natural history. Yeah, now it's actually very, very clear. We are not talking of curves anymore. We are talking of actually spikes and as such. Because one thing now we know very well that at the end of it all, most of us, if not all of us, will end up getting exposed and infected with COVID as it is. The only game changer really will be the vaccine. And the reason why you are seeing these spikes and surges and the like is dependent on one, availability of tests. Because when you can't test enough, then you may not know who is out there, who is actually infected. Number two, it is also dependent on who is presenting with the signs and symptoms. And number three, who is also being tested. So whatever you are seeing in terms of the numbers, when you hear a positivity rate of 5%, these are the only few people we are testing. We are maybe by now, I would actually guess that maybe 30 to 40% of us have been exposed to COVID, got infected, and maybe never showed any signs, major signs and symptoms, recovered, and we are actually going on with our lives. So whatever you are seeing coming through as 5% and what have you, that's just a tip and those are just suggestions from academia to give us a sense of decision making.
So if this is just the tip of the iceberg, Professor Anzala, then can it really fuel decisions that are made about how we should carry on? Because if we're saying 5%, okay, it's just an indicative idea of what the true case may be. We're not testing enough, like you've alluded to, not testing enough, so you don't get a true picture. So are decisions then made in the proper way if we're only getting just, a glimpse of what the case really could be?
Yeah, that glimpse gives you a good proxy to make decision on. But you see, the testing and the positivity rate is just one parameter. The other parameter we are also looking at, how many people are in hospital with COVID? How many of these individuals who are who have gone home to be isolated? But really a good indicator of really what would be the major problem is how many people are in hospital, in isolation facilities, in the healthcare facilities. How many of these are appearing as moderate to severe, and then how many of these individuals are in ICU? This is also a very good indicator of what is actually happening out there. So you can actually see that Europe now, the US, Britain, you can actually see even without issues of testing, they are overwhelmed with the number of people who are actually sick. That is another clear indicator. So for us, where we sit now, testing enough notwithstanding, we can actually say that things are not as bad, but we don't know what's going to happen in the next 1 month or 2 months, because we don't have as many people in ICU, we don't have as many people in isolation facilities, and we don't have as many people at home isolation. So you don't just look at one parameter, ladies and gentlemen. You bring all these parameters together, and then they actually help you make that decision as to what.
Professor, there's something that there's a question that has done the rounds, I think, with regards to COVID, and it is this. Anecdotally speaking, of course, that Africans in Africa, Kenya, our neighbors, are not as adversely affected by COVID as, say, the Europeans and the Americans. Now, two things: the truth about this, and if there's any element of truth to it, why is it so? And what brings it about?
Yes, very good. You see, observations are very clear. It is not only Africa, even India. We have a lot of colleagues we work with in India. India are also looking at the epidemic very clearly, realize that India is 1.1, 1.2 billion people. But India again was one of the countries where there had been predictions that it will ravage India and finish Indians because of the mass population crowding. But actually that has not come to bear. So it is true, even just by observations, before we even go into hard studies and what have you, just by observations, what had been predicted before is not actually turning out. The epidemic in Africa has not been as has been predicted. That is clear, that is observations. But you see, part of it is that we are not out of the woods yet, because part of it is that the epidemic or this pandemic is still ravaging a lot of parts. You have also heard that, as we had said before, that the virus has changed and the virus is also mutating. So we don't know what's going to happen in the next 2-3 months. But just looking back, because we can only look back, because there are two ways. This is living experiment where we look back and try to focus, the future. So it is true, Africa has not been hit as much as had been predicted. And for us, from where I sit, we are looking at several levels that there could be what we call non-specific cross protection. That things that we have come across in our environment, various infections, elevate our immunity, elevate some levels of resistance, such that when a virus such as this comes, whatever immunity we had built might not be specific to this virus, but that aspect of it not being non-specific assists most of us, even if we get infected, not to end up with severe disease. So the current theory, we are looking at what we refer to as, mucosal immunity, and this is the protection, the first level of protection, what we call innate immunity within the mucosal surfaces, because you realize that the infection actually begins in the upper respiratory tract, the nose, the mouth, which we refer to as mucosal immunity. So there is something there among certain individuals that is giving us some level of non-specific immunity, because we have looked for COVID antibodies prior to the emergence of COVID in this country, and we have not seen any COVID antibodies in our population.
There's a little bit of confusion, Prof, about what a vaccine will actually do, and I think it presents a great opportunity to explain it in the simplest terms possible, in terms of what a vaccine really does in the body. Because now there's talk of, and unfortunately misconstrued, that a vaccine will come and cure anybody who has COVID. Vaccine will 100% protect you from getting COVID. What exactly does this present now, even as this rollout talk begins?
Okay, vaccines, from the understanding, is actually a public health tool, and vaccines are geared towards prevention. Vaccines don't cure. Vaccines are meant to prevent. And vaccines will prevent you in this way. Vaccines can actually prevent you from getting infected, in the sense that once you are given that vaccine, it elicits an immune response. That immune response, in the terms we are talking about, is specific to COVID. So when that virus arrives, it finds a very clear, nice immune response that ensures that you don't get infected. That's one. Number two, vaccines can also work by preventing disease, meaning that you may get infected with COVID, but because you have already been immunized, then you don't actually develop disease. Or even if you develop disease, you don't develop severe disease, and then you also don't transmit this virus to anybody else. So those are the two levels traditionally where vaccines actually work. So for COVID, we are looking at two things: that either it will give you prevention from infection, what we refer to as sterilizing immunity, or it will give you prevention from disease. And you see, at any of this level is a win-win, because if it prevents me from infection, then it means that with time, we can actually eliminate and eventually eradicate. If it prevents us from disease, then really we will not overwhelm our healthcare system, because even if you get infected, the vaccine that you have been given will have elicited an immune response that ensures that you don't even need hospitalization. You might just have some common cold where you can be managed symptomatically, and you don't need any form of hospitalization. So those are the two levels of how vaccines work and how COVID vaccine is actually going to work.
I have a question that I'll ask about this, but I want to start first by asking, from your studies and observation with COVID-19, have there been many cases where somebody has had COVID-19, tested positive, recovered, tested negative, and then gotten reinfected with COVID?
Yes, there have been reports of that. And those reports are becoming more and more. And this is actually related to the fact that there are some individuals, even once they get infected, may not develop a proper immune system, proper immune response to the virus, or even if they do, that immunity declines very, very rapidly to levels where are not protective. And hence, if they become exposed again, they get infected. And that's why we are saying, even now, regardless of whether you are infected before or not, these vaccines will be given to all of us who are eligible, depending on how the government will organize. And we are saying that the vaccine is designed to elicit a better immune response than the natural infection. and give you a higher immune response, which will actually last longer. And that's why we are saying really all of us should be advocates of this game changer, the COVID vaccine.
Professor, could you please explain a little bit what it is that you mean by an immune response and why this immune response is beneficial to the individuals who will actually receive the vaccination?
You see, immune response means this way that there are two ways that we are protected from the ravages of various infections on a regular basis. Anytime you get exposed to an infectious agent, it will elicit what we call B cells, which will give you what we all know, antibodies. So antibodies are actually now soldiers, and these antibodies will be very specific to the infection that elicited this antibody. So if it is COVID, then these antibodies will be specific to COVID. Now, there's also T cells, which are also elicited. Again, these T cells will be very specific to COVID. So a combination of B cells, which give you antibodies, and a combination of T cells, then is what we actually call an immune response. So this is the immune response specific to COVID that we want this immune response to be there in sufficient quantities before one gets exposed to COVID, such that should you get exposed to COVID, this heightened immune response that is already there and specific will actually stop the infection, or if the infection occurs, stop you from getting any signs and symptoms of COVID. That's what we are actually talking about.
We also see that in many of the countries where now this vaccination has been rolled out, they're talking about getting multiple doses. In some, you get 2 doses. I think there are some that have talked about more than 2 doses. Why is it important to get 1 dose and then take a couple of days and get the second?
Yeah, it is a phenomena we call prime and boost. What you're doing is like the first, vaccine is priming. The first dose primes, the immune system. And then after 21 days, the second dose now comes and heightens that immune response even further. And that is a phenomena that is not is not new. You saw that previously we used to give measles only once. Now we are giving measles twice. You have seen that we used to give hepatitis B, for example, it's given 3 times. All right, polio, we give a variety of more than one. We give polio 3 times. So really the whole issue is that as you give additional doses, what you are doing is that you are actually giving the immune system a booster to heighten that immune system so that it will go in. If there were certain B cells specific to COVID at this level, when this vaccine comes in, it even takes these B cells to a much higher level so that your memory, because eventually what is important is what is left behind as memory. That memory is much heightened. And that's why you find that under normal conditions, we normally give the first dose, and then we want to boost later on to ensure that we heightened the immune system and have a higher memory of B cells and T cells so that the vaccine can last longer. That is the point. So that not the vaccine, but the immunity can last longer.
Okay.
Yes.
I want to ask this question because of the position you hold within the advisory group on this particular matter in the nation. 1, what is our preparedness? I mean, the details of our preparedness. 2, what is it that we've done with regards to ensuring that people, or have we set in motion that the individuals in this country will fully understand what the vaccine is all about and how it will be administered? And 3, are we going to talk about publicly how we are going to prioritize it and how it is we are going to actually distribute it?
Yes, you see, we are in a very unprecedented time, ladies and gentlemen. And not only Kenya, globally all over. The experience the world has had is the experience of giving vaccines to under 5s, 0 to 5. That is experience childhood vaccines. We are now talking of actually giving vaccines to adults outside of this paradigm where we have always known that vaccines are for children. Now, so there are three levels here. We are talking of vaccines. And for us, really, the issue is that what vaccines will be appropriate, for Kenya and appropriate for maybe Africa. All right?
Here we are talking about vaccination of adults. The government is used to dealing with children, and there are things that need to be put in place. So what about that?
Yes, actually, so there are three levels. There is the vaccine, there is the vaccinators, and there is the vaccine. The vaccine, the appropriate vaccine will actually be, for us, will be the Chadox vaccine. And this is the one that is stored at 2 to 8 degrees. And that's why we say that Africa must choose the appropriate, and Kenya will choose that. So the vaccine, the only issue with the vaccine is maybe costs involved, and who will actually buy it for us. But what I hear now is that the government is putting in 24 million doses. And if you say 24 million doses, that will mean you're only going to give it 12 million people, because each person requires 2 doses. Exactly. And then what we have also done in terms of vaccinees is that we've actually said that this vaccine will first of all be given to healthcare workers because of risk of exposure and infection. And then number 2, it will also be given to people with comorbidities, people with underlying conditions, because of also risk of severe disease. Then we have also talked of health of teachers because of the exposure to children, and we know that children may have COVID and not present with any form of disease. And then we are also talking of men and women in uniform. So far, this is the group that government is actually prioritizing for now. These individuals are amounting to around 11 to 12 million. So if we can get these doses, so the vaccine might not be a problem. The problem now comes with the vaccinators. And within these vaccinators is the elephant in the room. And these are the logistics. What would it take to actually vaccinate 11 million people? How long do you want this to take? That is the elephant. So when I say vaccinators, I mean the logistics of bringing this vaccine at the airport, moving this vaccine within the cold chain from the airport to the various facilities that have been designated as facilities where these vaccines will actually be administered, and ensuring that it's cold chain, having enough healthcare workers to ensure that they are there 24/7 to administer this vaccine, but ensure that other healthcare programs continue completely uninterrupted. So that second thing of vaccinators and the attended logistic to it is actually the elephant in the room. And that's where we shall either make or actually break. Realize, for example, the US had said that by the end of 2020, that is end of last December 2020, they had estimated that they should have vaccinated 20 million people. By end of December, the US had only vaccinated 2 million. Not because there was no vaccine, but it's because of this second aspect of vaccinators and the logistics of it. So it's the healthcare professionals who need to do that, and the facilities and the distribution network that is required. Then the third thing is the vaccinees, the individuals, these healthcare workers, these comorbidities. Where are they, and how are we going to reach them? Are we going to be walking from house to house, or are we going to have a standalone sites where these individuals will be invited to come? So these are not easy matters, ladies and gentlemen. There is a group working on this, day and night, but this is where the whole issue of working with adults and ensuring that as you do this, all your other healthcare workers, all your other healthcare programs actually go on. So vaccines, the vaccinators, and the vaccinees. So by now, really,
there's a small matter that is specific to Kenya, and this is something that the public would like to know. The plans for distributing the vaccines to the counties. You've laid it out beautifully and it's easy to understand. But the vaccines will definitely go to counties. How exactly is the government going to distribute them? And one. Two, what is our current status in terms of the ready population of healthcare workers who are able to actually administer this vaccine? And I say this against the backdrop of all the sackings that we've now read about and heard about
And
of
strikes
of healthcare workers. Against this background,
I'm telling you, ladies and gentlemen, as I'm sitting here and I sometimes cry for our healthcare. We are in turmoil. Ever since we went into this devolved system, we are totally healthcare, the public healthcare system is falling apart, as we watch. My prayer, and we are trying to tell government, COVID vaccine and administration of COVID vaccine cannot be left to counties. This must be the Ministry of Health from the central region, ensuring that they will say, if there's a facility in Kakamega, it will be managed by these individuals. If there's a facility in Kisumu, it will be managed by these individuals. So it cannot be that this vaccine is picked from here and just taken to Kakamega and left there. If that is done, it will be exactly what is happening in the US. That's exactly what happens in the US. The US picked these vaccines and took them to the various various states and said now the state takes over in terms of the vaccinators. And this is what I mean by the logistics. And most of them were actually not ready. So for us, really, let's learn from the others. Britain has done it very, very well because it took the charge centrally, so that even if you are moving and saying that I'm setting up base in the Western region, then it has to be managed from the central office. We should not again say that healthcare is devolved and then we take these vaccines to the regions and live there. If we do, it will get wasted. So what we are trying to advise government is that we don't want house to house. Let us have fixed sites, fixed positions, depending on how much money they have, how much healthcare workers, and then begin to communicate to communities with the various, the ones we have actually listed, and have a plan. How many can we do per day? How will they actually come? That is the aspect we are saying. But my prayer is that we cannot say that we move this to the county and live there. At the status where we are now, most of the counties are totally understaffed, ladies and gentlemen, in terms of all aspects of healthcare workers, from doctors to nurses. So you cannot again expect the same doctors and nurses and clinical officers and others who are already on their day-to-day job to be the ones to be plucked to go and do this aspect of it. It will not happen.
Okay, so the vaccine comes next month. We're talking about a matter of 3 weeks. That's when the deployment will happen. And this plan that you talk about, Professor Anzala, necessary to be put in place in order to see, because obviously, like you said, it's not just going to come here and then we're going to guess what's going to happen. Plan needs to be put in place. When do you think that this plan should be put in place in order to have things ready? Shouldn't it be by now?
The plan should be by now. Now we even should have actually done dry runs. The plan should be now. The healthcare workers who are going to administer this vaccine should actually be on board. The sites, the fixed sites we are talking about, should actually be there. My approach should have been that these fixed sites should not necessarily be hospitals. We are not vaccinating sick people. We are vaccinating healthy, normal people. These sites should not really be hospitals, but should be sites that are already up, identified, And we should now be talking to the communities that if you have this and this is exactly where this vaccine will be available. These are the healthcare workers. We should actually be doing dry runs. And I'm talking like this because India has actually done that. India wants to vaccinate. They are talking of 100 million people. Can you imagine? Yes. They are talking of in the regions of 100 million people. So how do they do that? It's not a walk in the park. By now, ladies and gentlemen, we should actually be seeing discussions of the fixed sites, discussions of the healthcare workers who are being trained will actually administer these vaccines. Logistics should actually be in place in terms that we have the right storage, conditions. We have needles and syringes. All these things should actually be available. The individuals with comorbidities in the various regions should have been mapped out. We should be knowing Kakamega, there are 30, maybe 2,000 people. And then I forgot actually the elderly, those who are actually 55 years and above. That is part of this group. So we should be knowing how many are they, so that when now you are moving the vaccine, you know very well, I'll take so many doses to Western region, so many doses to the Eastern region, so many doses to Coast. So really, it seems easy, but it is totally not easy. And if we just learn from what the US has experienced, estimating to do 20 million people, and you only end up doing 2 million, tells you that even in the best of conditions, there are going to be difficulties. So for me, really, we should not just be hearing that we have ordered 20 million. That's not enough. That's the easy part, that is the easy part, bringing the vaccines in. But the difficult part is the vaccinators and the vaccinees. And the vaccinators have unpacked for you is all that logistics, cold chain, healthcare workers, the storage, the movement, and then getting to know, do the elderly already know that they are going to be the first priority? I don't know.
All those things that you're saying, Prof, to the best of your knowledge, because you sit in a position where you have access to the information of what is happening in terms of the planning and the logistics and putting in place all these measures that you've said. How far have these conversations taken place? To the best of your knowledge, with about, let's even give it 6 weeks' time, with a 6-week lead time, are we anywhere close to even starting to identify, for example, who are the vaccinees going to be, and the vaccinators and the logistics? Have we started that?
Yeah, the process started. The process actually started last year. The first thing was really to figure out. We didn't want to raise high expectations and then fail. We wanted to wait a bit and see the data coming out of the three top candidates: the Pfizer, the Moderna, and then the AstraZeneca ChAdOx vaccine. And once the data was actually good, it was clear. And then also being part, Kenya joining the CDC, the COVAX agreement, so that they can also put this. So discussions actually started around October, November last year. They are actually going on, at a very heightened, speed. And that's why I'm telling you, all these things I'm talking about are all being discussed. They are on the table. It is not easy, but my only fear is that we are a bit delayed. We don't want, the vaccines, the doses to arrive, and then we don't begin immediately. So we are actually really trying to push the ministry further to ensure that we are up there and we are already communicating to ensure that things are happening. Even if we can't do each county, then can we actually agree on regional to allow us to have actually regional, because no more people can travel. If I'm told the vaccine is being given in Kiambu, I'm in Nairobi, and I'm told book, I can't go to Kiambu because I'm not sick. So that's exactly what we are saying. So these things are critical. And then also beginning to address the skeptics. We have a lot of skeptics, and we have a lot of those we call vaccine hesitancy. people who cannot make a decision quickly. So again, we should be having, communication, and I'm glad we are talking about this to address the issue of skeptics, because there are people who are rumor mongers who are giving information, oh, this vaccine has not been tested very well. So all these things should actually be addressed, because you also don't want to spend so much money with a product only to end up that a lot of vaccinees who are eligible are also not showing up.
So is the message then, Prof, that the vaccine is here, come out and get vaccinated? Is that the message then that should run through with all of these other plans and logistics that are being set in place?
Yes, it really, when we say healthcare workers, you see that there'll be organizations in Nairobi, in every county. They will be organized in such a way that how do the healthcare workers access this and through what system? Maybe healthcare workers, a vaccine can be taken to the various institutions and they are given. But for the rest, individuals with comorbidities, teachers, the elderly, men in uniform, the game might actually be different. So the idea is that we should, by now, we should actually be having very good communication saying that the first priority will be this segment of society. This is how they are defined. This is who they are. So if you fulfill any of these criteria, please know that you'll be the priority, and this is exactly where you'll actually be required, or this is what you'll be required to do ABCD. And do dry runs. For me, I come from experience where I've done a lot of clinical trials, phase 1, phase 2. We always do dry runs to ensure that everything is in place. And also realize that there are two aspects people are also not talking about. This vaccine is being given under what we call emergency use authorization, meaning that the clinical trials are not complete, as opposed to a vaccine which goes through all the clinical trials. It is licensed and then in various countries, and then it's administered. So emergency use authorization then requires that also those individuals who are being given the vaccine need also to consent, because it is also part of like an extended phase 3. So there'll be need to also collect a little bit of data to ensure that you are also collecting a bit of data. Are there any additional side effects that are not being seen? So this is the real understanding of emergency use. So there are two aspects: emergency use authorization and the use of vaccine that is already gone through the entire process, been proved to work, has been licensed. So Africa is just Kenya, and individuals can license and actually bring the product.
What is the likelihood that the things that you have mentioned, and again laid out very, very clearly, will actually be organized, brought to bear, so that when we do get the vaccines, we are actually able to administer them to our people? On a scale of 1 to 10, what would you say is the likelihood?
Now that you're putting me on the spot.
Professor, that's not the idea, but go around it and explain it in a way that doesn't put you on the spot.
You see, for me, really, from what I've seen, Kenyans, and maybe you guys can also let me know, actually Kenyans are acceptable to these vaccines. A large majority of Kenyans are acceptable to these vaccines. So we will not have problems of vaccinees. The only thing is that we need to organize it very well so that these vaccines can actually, the vaccinees can actually be told how and when to get to the immunization centers. The biggest problem really is the vaccinators, getting enough logistics from the healthcare all the way to ensuring that there is cold chain and everything else. So the major problem will actually be that second aspects of vaccinators with the attendant logistics. So what I can say, okay, let me just be bold enough and say between the scale of 5 to 10, we might be hovering around 5.
Well, I think you're being very generous.
Thank you. At least Yes, with 5 there's hope.
Yeah, and that's what I'm actually saying. 50%. We can do that with all the difficulties, but also the whole issue will be funding. Funding is not easy because, again, these vaccinators will not be volunteers. I'm sure these will be people who need to be remunerated for the hard work they will actually be, be doing, because vaccinating 11 million people, gentlemen, is not easy. And the issue is the duration. The longer you take, then it becomes useless, because you want to be able to say, I'm giving you a vaccine now. Today is the 6th. Within another 21 days, I want to give you the second dose. And that's when now we say you are fully immunized and you are fully protected. If that doesn't happen, then we shall have individuals who have a partial immune response to this virus. And this is from the understanding of immunology. Now, this is the environment that actually enhances mutations.
We've seen that issue, the logistical issue, actually cropping up in the UK as well, where they were supposed to get now the second dose after 21 days, and then the government came and said, you can do it even within 3 months. What is the longest that you can take between dose 1 and dose 2 for it to be still be effective?
From the data we have received, out of the 3 vaccines, 21 to 28 days. Yes. And from the virology and immunology point of view, when you are partially immunized, you are actually, 1, a risk to yourself, and then 2, you risk that if you get infected, the virus is partially, the immunity partially handles that virus, and it doesn't handle it very well. And it is this kind of partial immune pressure that enhances mutations. And these are the mutations. Mutations can go either way. You can have mutations where the virus actually mutates itself and disappears, like the SARS-CoV that appeared in 2002, 2003. That virus was only in Asia and it disappeared completely. So it mutated itself out of existence. Or the virus could actually mutate, become more severe, and actually become endemic. And that's what we want to try and avoid.
Okay, so I mean, we're looking at it. It's, I mean, the way you've explained it, very clear in terms of what needs to happen, and then we have a situation in the country which doesn't quite allow for the flowing, health services that we would like. And now here we have a situation where we require the health services or health workers to be in tandem with government for the adequate and proper rollout of this. Would you then advise at this point that government gets all its ducks in a row in terms of, being in good stead with health workers, for this, if not for anything, for this purpose alone, to say, fix this in order for us to then get the logistics in order for vaccination of Kenyans?
You see, we talk, we on a regular basis. Some of the CECs in the various counties are actually our colleagues, medical doctors, just like us. The healthcare problem, ladies and gentlemen, is a big problem. The Kipia doctors have never been resolved, which is the other county, Kisumu. We have had upheavals, very insufficient terms of human resource levels of employment. To me, if something can be done and be done, very quickly, we might be sitting pretty saying that, we have not seen very severe outbreak, or the predictions were actually not as have not come true, but the virus has actually not gone away. We are now hearing of mutations in South Africa, some variants in the Congo. I mean, not Congo. I think Angola and the like. There's the variant in Britain. We have also had variants now in the US, and these variants look more infectious. So we actually don't know in the next 3 months how our epidemic is actually going to turn around. And there is no proof that these variants they're talking about are not here. because Britain only got to know because they were sequencing these strains at a much higher level than any other country. That's why they were quickly to identify this. So really, I don't know if you guys are in a position to talk to the governors and what have you, call them, just tell them that we want our healthcare system to go back for now, for the sake of COVID. COVID has not gone away. We see the fears that are there in schools. We are urging our colleagues in the various counties to go back to work to stop this strike. Things can be agreed on amicably on the table. You can be promised pay later, but also ensure that salaries are paid to healthcare workers. It's amazing, ladies and gentlemen, that there are people who are employed, go to work, and can actually go for 2 to 3 months without a salary. It is unfair.
That's
Totally
very true.
unfair.
Prof, when you talk to the governors, the ones that we speak to, they tell us they are on top of things. It's only that the workers are the ones who are pulling
Not
them
being
down.
cooperative.
So, I mean, we are where we are as a country, and sometimes the kind of frustration that we hear from professionals such as yourself, you're sitting here, you're saying, we are not yet out of the woods. In fact, we do not even know where we are, at what point we are in the woods. And then we see those who have been given that responsibility acting as if, well, it's just one other day. The sun is rising, the sun is going to set. Then it gets frustrating for all of us. But thank you very much, Professor, for speaking to us this morning. We hope to speak to you again soon.
No, any day, and just let's deal with the skeptics. Let's deal with those with the hesitancy. There's really no problem with these vaccines, the way, they have been tested. I understand immunology and vaccines, very well. So let's keep talking. And my hope is that the things we've talked about, maybe in the next 1 week or so, you'll actually begin to hear more detailed information about, the vaccine, the vaccinators, and the vaccinees. Thank you.
My God, we just hope so.